A few weeks ago, I was called to the ED to see a patient who had sudden dizziness, nausea, vomiting, and diplopia. Without getting into too much of the details of the case, the patient had structurally normal neuroimaging, no evidence of vertebrobasilar disease, and no vascular risk factors. However, the patient had been having more frequent headaches recently, headaches which weren't responding to over-the-counter NSAIDs and acetaminophen. And within 2 hours of onset, this gentleman's acute vestibular syndrome became a migraine headache. Now, migraine can cause all sorts of negative and positive symptoms, as we'll be discussing in today's program.
Typically, the symptoms precede the headache.
And whether it's an expressive aphasia, focal or generalized weakness,
anything can happen, right?
Visual obscuration, or sensory dysesthesias,
they can also occur without the headache.
It's worth knowing the full spectrum of neurologic manifestations of migraine.
It is not just a headache.
After all, June is National Migraine and Headache Awareness Month.
Migraine Awareness Month, June, every year.
So while we're all certainly occupied with this virus that's going around, we can't forget about these other medical conditions that can present in unusual ways, and they still ought to be recognized.
It just makes it a little trickier to diagnose.
Welcome back to Brainwaves, a podcast about neurology and medicine and all the fascinating science and history that come with it. Today on the program, migraine with atypical features, from the migraine with brainstem aura, as was the case that we just mentioned, to migraine aura without headache, which some might call the acephalgic migraine. We'll cover some of the less common phenomenology of this headache disorder. Don't go anywhere. Okay, excellent. I think we're ready to go. For today's show, I spoke with Dr. Deborah Friedman, who you heard moments ago, who's a neuro-ophthalmologist by training, but she also wears the hat of a headache specialist.
I'm a professor of neurology and neurotherapeutics and ophthalmology at the University of Texas Southwestern Medical Center, and my practice is mostly focused on neuro-ophthalmology and even more importantly, I think, headache medicine.
For me, migraine is one of the primary headache disorders which is associated with more than just head pain. And this sometimes can make it challenging to diagnose, but also it can make it easier to diagnose. Can you comment on the spectrum of symptoms that are associated with migraine that really have nothing to do with head pain?
Sure, and you're absolutely right. Migraine is much more than a headache. So people with migraine will often have neurological symptoms even before they start to have the headache. So people will sometimes experience unexplained mood changes or food cravings or sensitivity to light or noise, other unusual kinds of neurologic symptoms like uncontrollable yawning even.
Dr. Friedman also reported the case of a patient with hiccups as a migraine aura.
That kind of give them a sense that their migraine is coming. And then about 25% of people with migraine get what's called aura. And aura just means there's a fully reversible neurological deficit that usually precedes the migraine. And some people have more than one aura symptom and others do not. So the most common aura symptoms are either visual, sensory, or speech and language related. And the visual aura can be either what we call positive or negative. Positive means that people see things in their vision that really aren't there, usually flashing lights or shimmering zigzag lines in their peripheral vision.
The geometric or angular nature of the visual phenomena in migraine,
looking through cracked glass,
or undulating and slowly mobile phenomena,
heat rising off the pavement,
should make you think of something like migraine as opposed to any other neurologic or psychiatric condition that can lead to a visual disturbance.
Sometimes these things come on suddenly, sometimes they come on gradually and they progress for about 15 to 20 minutes or so. There can also be negative symptoms, so people can completely lose their vision. They can lose their peripheral vision. They can lose half of their vision, homonymous hemianopia. They can have problems with their central vision. So the visual symptoms by far and away are the most common of all aura symptoms.
As many as 90 to 99% of patients with auras will report visual phenomena.
The next is sensory, which is generally, again, either positive or negative.
And seen in probably a third of patients with migraine with aura.
But usually it's positive, meaning people feel stuff that's not really there. And it's generally described as tingling. So people will often say that they get tingling in their face or tingling of their arm or their hand, and it kind of marches up all the way up the arm, goes into the face, may go to the other side. And so that often helps us distinguish between a migraine and a TIA. Other people will have true numbness. They just can't feel the body part involved. And then the last is speech and language.
Disturbances of which are seen in about 10% of patients with migraine with aura.
It's not so much slurred speech, it's aphasia. The person knows what they want to say, and the words just don't come out right. They're talking, as one of my patients said this week, gobbledygook. They can't even understand what they're saying. And so, again, that could be sort of worrisome as being a TIA or stroke the first time it happens, but it's not that unusual with migraine.
So those are the three common types of aura, but they aren't the only variations of neurologic symptoms that are seen in migraine.
Some people get a sort of depersonalization during a migraine. They feel like they're detached from the world.
Some people feel a nonspecific fatigue,
Cognitive dysfunction.
dizziness and imbalance, and sometimes focal neurological deficits.
There are just all kinds of different manifestations that can occur outside of the headache.
As a vascular neurologist, it sounds like a lot of these are inextricably linked to other conditions like stroke. I mean, you already mentioned TIA several times, stroke several times, and kind of producing similar symptoms. What tilts the needle towards migraine or towards stroke or seizure or some other neurologic or non-neurologic condition?
Sometimes that can be really hard to figure out. The things that help distinguish migraine from stroke regarding the aura symptoms are that migraine aura symptoms tend to come in succession. They march. People who have a stroke or a TIA, they generally have a sudden onset of neurologic dysfunction. So they'll get weakness and numbness and speech problems all at the same time. People with migraine will generally start with one. It'll evolve in 5 or 10 minutes and they'll get something else. And then in another 5 or 10 minutes, they'll get something else. The other thing that helps us to some extent is a history of migraine, but that's not foolproof because people who have migraine, particularly migraine with aura, are at an increased risk of stroke. So that doesn't necessarily, tilt the needle one way or the other.
You might also get a history that these attacks are stereotypic of the patient's prior symptoms.
The person has had these attacks before. They're always very, very similar.
But if it's the first time the patient's experiencing sudden onset loss of vision in one eye or a hemifield, or sudden word-finding difficulties, with or without headache, you would not want to miss the diagnosis of an acute cerebrovascular event.
It's interesting because many of my hemiplegic migraine patients are referred from either the stroke group or the emergency department, and they often get admitted.
So whether it's getting vascular imaging, getting an MRI,
especially if they're older, especially if they have vascular risk factors,
or whether it's looking for metabolic disturbances, toxic states, considering functional disease, you'll want to do this for a first ever neurologic event.
I think it's pretty standard.
Standard.
Epilepsy tends to be a little bit different than stroke, and usually that's easier to figure out. The visual manifestations of epilepsy are usually quite different than the visual manifestations of migraine aura. And what people with epilepsy usually experience is colors and blobs in their vision. They don't have triangulated patterns like migraine does. People with epilepsy could also experience weakness or numbness. Now, typically the weakness in epilepsy comes after the seizure.
Sometimes you'll know this by history, but if there's no one to recount what had happened, because there's a pandemic and people are isolating themselves socially, then maybe checking a CK to look for muscle breakdown could be helpful. I personally like to get a perfusion CT in this circumstance because in more than half of patients who have a postictal TODS, there will be a region of cerebral hypoperfusion in the affected hemisphere without any evidence of an intracranial occlusion. But numbness or dysesthesias would not be typical for seizure.
The numbness of migraine comes before the headache attack, but it can march just exactly the same way migraine marches, although typically it marches a little bit faster than migraine. And there is an overlap between epilepsy and migraine. It's a comorbid condition. People with migraine are more likely to have epilepsy. People who have epilepsy are more likely to have migraine.
Observational studies have found that epileptic patients are more than twice as likely to have migraines than non-epileptic patients, and this is likely related to a genetic predisposition. We know some of these genes very well. For example, a mutation in CACNA1A, ATP1A2, and SCN1A genes can result in one of 3 autosomal dominant familial hemiplegic migraine syndromes, which have a known association with epilepsy. But headaches in general among epileptic patients are also common. As many as 40 to 60% of patients with epilepsy will experience a periictal headache. For the most part, these headaches will occur after the seizure. So this episode is all about kind of these variants of migraine that produce these kinds of less than common symptoms. I mean, migraine not uncommonly is associated with aura, is not uncommonly associated with visual obscurations and nausea, vomiting, photophobia, phonophobia. These are kind of the hallmark symptoms that all med students and residents are taught. But I want to focus on a couple of key examples of just strange variants that you should not miss, I guess, for any neurology resident who's listening. Of the more specific kind of atypical migrainous conditions, I want to start with hemiplegic migraine. And I tend to see a lot of patients like this in the ED. They come in, they say they have a history of migraine. It's not really clear to me that they do have a history of migraine. They're not really seeing a headache specialist, but they have a history of headaches. And then all of a sudden they have new significant weakness. And it's hard to know if that's really migrainous, if it's stroke or TIA or something else, or if it's more of a functional neurologic disorder. So in somebody who has the new first ever headache with associated weakness, or weakness in the history of headache but no headache, what kind of drives you to think that it's migraine related?
I would be a little reluctant to make the diagnosis of hemiplegic migraine in the absence of migraine headache. You certainly can have migraine symptoms without having a headache, but that one would worry me. So to have a diagnosis of hemiplegic migraine, you have to also have typical aura symptoms, visual, somatosensory, language dysfunction. Okay, so somebody is not going to come in just with weakness. Familial hemiplegic migraine is autosomal dominant,
which we just said can be familial, and due to mutations in CACNA1A, ATP1A2, or SCN1A genes.
So generally, we will get a history that there was a family member that also has this.
Or the hemiplegic migraine can be due to a de novo mutation.
You can also have just sporadic hemiplegic migraine. And even though it's called hemiplegic migraine, the name is almost a little misleading because the patient doesn't have to have complete weakness, which is hemiplegia, and it also doesn't have to be on one side only. So some people with hemiplegic migraine actually get bilateral weakness, and it doesn't have to be face, arm, and leg. So a lot of people will just get arm weakness and not get much of anything else. So you just have to be aware that it doesn't have to look like a stroke, but not really be a stroke. There is another sort of variant on the theme, which is called MUMS.
Migraine with unilateral motor symptoms.
And it was described by my colleague Bill Young at the Jefferson Headache Center. And these are people that have migraine, and they develop what you would think of as sort of a typical hemiparesis or hemiplegia. But when you examine them, which is really the key to all this, you find that there's really no organic evidence, right? A hard evidence that this is really a problem that's coming from the brain. So the reflexes are intact, the tone is intact, the patient has giveaway weakness, that kind of stuff.
They have a functional exam.
And often these patients are totally convinced that they're having a stroke. And even though they're being told they're not having a stroke, they're still convinced that they're having a stroke.
I hate that I'm a vascular neurologist and I feel like a hammer. Everything looks like a nail to me. But one of the other variants I wanted to talk about was retinal migraine. And I see that, and I'm always ruling out amaurosis. I'm always ruling out other causes of ischemia. Tell me about the natural history of retinal migraine, how that ties into migraine. Is it really truly retinal, or is it cortical, or where is it coming from?
Right. Well, the true name for this problem is retinal migraine. It comes from the retina. It's thought to actually be caused by retinal spreading depression, which is very similar to what we see in the cerebral cortex with regular migraine, which is caused by cortical spreading depression. So there is this wave of neuronal hyperexcitability followed by relative oligemia and decreased excitability that propagates through the retina. And this has actually been shown experimentally in several animals, including the chicken, among others. I wouldn't lie. And Again, similar to migraine aura, patients can experience either positive or negative visual phenomena. It makes us feel better when they're positive. So when they're seeing flashing lights and zigzag lines and whatever they're seeing, that's actually a little more assuring than I lost my vision, right? Because when people lose their vision, there are a lot of bad reasons that can happen, and they often need a workup. People tend to call this ocular migraine or visual migraine, and there actually are no such diagnoses as ocular migraine or visual migraine or eye migraine. And unfortunately, it's my colleagues in ophthalmology, I think, that are kind of spreading this bad terminology. But retinal migraine, by definition, is monocular. So the patient has to, cover one eye, cover the other eye. It's definitely only happening in one eye.
At least for a given episode, it's only in one eye, but sometimes it can go back and forth.
It can switch eyes.
And that makes us even more reassured that it's a retinal migraine rather than an embolic vascular event or retinal hypoperfusion, especially if the visual impairment resolves over minutes to an hour or so.
Less than half an hour usually, certainly no longer than an hour.
And certainly helpful to know that the patient's young, without vascular risk factors, and has a negative review of systems for giant cell arteritis if they're older.
There was a study that was done, I think, back in the 80s, and they looked at patients who had transient monocular visual loss.
It was the 1989 paper by Tippin and colleagues, which is referenced in the show notes.
And this was like back in the days when the best we had was catheter angiography. So they worked up all of these people and they did arteriograms on them. And what they concluded was that if the person was having these episodes of transient monocular visual loss, if they were under age 40, chances were overwhelming that this was migraine or vasospasm.
In that study of 83 patients under the age of 45, 41% of the included patients had headaches, which accompanied the vision loss, and another 25% had a history of severe headaches, suggestive of migraine. Half of the overall cohort had a family history of migraine as well. And like Dr. Friedman mentioned, 11 patients underwent cerebral angiography, but only 2 of these patients had any abnormality whatsoever. One patient was diagnosed with Sneddon syndrome, which is a thrombotic, non-inflammatory vasculopathy, so no surprise there. And the other patient with an abnormal angio had a focal stenosis of the ophthalmic artery. Importantly, not a single one of the 83 included patients developed a stroke, regardless of the duration of their visual symptoms.
But there is also this entity of retinal vasospasm that actually occurs probably behind the retina, and it also can affect arteries in the retina and veins in the retina. It's been visualized. That can also cause transient monocular visual loss. It's thought to be kind of a migraine variant. We treat it with calcium channel blockers.
Like nifedipine or verapamil.
But they can also occur without the headache. So retinal migraine can occur without having the headache. And that's when it gets really difficult to figure out.
And that ties in perfectly with my next question, which is kind of this concept of the acephalgic migraine with aura without headache or something. What's the true term?
The official, international classification of headache disorders is migraine aura without headache.
Okay. So tell me about that.
Usually it is somebody that is experiencing one of the many aura symptoms you can get. And sometimes they have it with headache and sometimes they don't. But there are certainly people who never have headache. And abdominal migraine is one of those variants where people just don't get headache. Transient vision loss is another one. Usually in people who are older than about age 60 or 65 that have this whole flurry of events. And they may or may not have a previous history of migraine, but all of a sudden they'll develop just numerous events of transient vision loss, one eye or both eyes, that just keep occurring. And they can happen more than once a day. Sometimes they just happen several times a week. And they go on for a while, and then they usually stop. It was described by C. Miller Fisher way back when, giant in stroke neurology.
Mm-hmm.
That can certainly happen without headache.
So by this point, we've covered the overlap between migraine and epilepsy, migraine with aura, hemiplegic migraine, which can be familial and autosomal dominant or sporadic. We've covered retinal migraine, which shares some commonality with vasospasm and a spreading depression pattern over the retina, not unlike cortical neurons, and then migraine with aura without headache. Another migraine variant also intrigued me, So I made sure Dr. Friedman and I talked about this condition as well.
Well, it's gone through a few name changes, so that makes it confusing too, right? So it used to be called basilar artery migraine, then it was called basilar type migraine, and now it's called migraine with brainstem aura. So these are people, again, who by definition also have to have typical aura symptoms in addition to brainstem aura symptoms.
You should be seeing the common thread between each of these variants by now.
So they can have dysarthria, they can have vertigo, tinnitus, hearing loss, double vision, imbalance, ataxia, even loss of consciousness.
The third edition of the International Classification of Headache Disorders defines migraine with brainstem aura by the following criteria. First, a patient must experience at least 2 attacks of the migraine with brainstem aura. Second, there must be a preceding aura of visual, somatosensory, or language symptoms, which are fully reversible. Third, at least 2 brainstem symptoms, dysarthria, vertigo, tinnitus, hyperacusis, diplopia, impaired consciousness, that kind of thing. Fourth, the patient must meet 2 of the following subcriteria. Progression of symptoms, or lateralization of symptoms. Symptoms must last 5 to 60 minutes, and or they're followed by headache. And fifth, there's no better explanation for these symptoms, and a vascular event has been ruled out. Dr. Friedman actually recounted an interesting case about this from earlier in her career.
I've seen this a couple of times, loss of consciousness. And the one patient that really sticks out in my mind, I saw when I was early in my practice in Syracuse, New York. And it was a teenager who came in because every so often she would leave for school. She lived in an apartment. She'd go into the stairwell to go downstairs, and somebody would find her passed out in the stairwell 2 hours later.
Oh my God.
She never made it to school.
Oh my God.
And, she had this huge workup and multiple EEGs and everything we could think of to see what was giving her these spells that would last for hours. And we finally concluded that it was migraine with brainstem aura.
Because every other possible cause of her loss of consciousness was effectively ruled out, and after more detailed questioning, there was a very clear trigger of her events, a trigger that has a known association with migraine attacks.
It turns out that her trigger was aspartame, and she gave up aspartame. And
Just Diet Coke.
Went away.
I mean, she was just like, that's what she would have before class. It's like a diet soda or something.
I don't remember, but I did treat her. I think I put her on verapamil at the time, but that is what eventually got rid of her episodes.
Which is also a kind of diagnostic test in and of itself, diagnosis by response to treatment. But like we mentioned at the beginning of the show, having a clear-cut story for history of migraines, or family history of migraines, or a prior stereotyped neurologic event, these are convenient historical details in the evaluation of a patient who has atypical migraine symptoms. Yet, often the clinical features are not so convenient. In some patients with migraine-type symptoms, you have to keep an open mind and a broad differential diagnosis. Could the small T2 lesions on MRI represent CADASIL, cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy? Well, if they're anterior in the subcortical temporal lobes, or if they exist in the extreme capsule, then yeah, that would be concerning for CADASIL. Or does the patient get transient vision loss in one or both eyes, severe headaches, and maybe they've been taking retinoic acid, or they're overweight? Could they have idiopathic intracranial hypertension? Or maybe the patient has a migraine overlap syndrome with something else.
I do have a fair number of patients who also have trigeminal autonomic symptoms with their migraine. And it really seems like it's a combo almost of migraine and cluster. So it's not that unusual to have trigeminal autonomic symptoms with migraine, conjunctival injection, tearing, ptosis, eyelid edema, stuffy nose, runny nose. The whole stuffy nose and runny nose thing is why people often ascribe their migraines as sinus headaches.
Mm-hmm.
But it's not unusual at all. But
There's an interesting observational study out of JNNP by Rozen and colleagues, which summarized this overlap between cluster headaches and migraine at the Jefferson Headache Center in Philadelphia. While cluster is traditionally a disorder more common in males, in females with a cluster headache, there's a much higher prevalence of nausea and vomiting, like Dr. Friedman said. Vomiting was 3 times as common in that observational study of 102 patients. Other migrainous symptoms appeared equally common in women and men, but they were still common among all cluster headache patients, with photophobia in 3/4 of patients and phonophobia in half.
But often these people do turn out to have cluster headache. They just also have migraine symptoms that go along with it. And unfortunately, they get misdiagnosed as having migraine, and they really have cluster, and the treatment for cluster is completely different than the treatment for migraine. So they often end up, suffering for a long time before somebody figures out what's really going on. So sort of my take-home message is if the patient sounds like they have cluster and they meet criteria for the diagnosis of cluster, even if they have migraine symptoms also, don't let that stop you from diagnosing cluster.
Is there any reason to think, or is there any evidence that shows that patients who have these atypical migraine syndromes, they have any poor quality of life, or their migraines are more severe, or there's something different about how their disease progresses compared to patients without these variants?
Other than hemiplegic migraine, I would say overall either no or it hasn't been well studied, right?
Yeah.
So hemiplegic migraine, sometimes patients who have really severe hemiplegic migraine, as they get more and more attacks over time, the cumulative effect is that they can get permanent weakness. And usually that comes on gradually over years. But in general, I would say I'm not sure that it's any more disabling or quality of life affecting than having migraine headache, unless the person is having symptoms that are precluding them from doing something.
Like their migraine causes them vision impairment, which keeps them from working at their computer, or their migraine causes weakness, which prevents them from maintaining an active lifestyle. A quick note about treatment before we wrap up. With these more particular migraine variants, is there any more of a particular treatment that works best for them? It turns out, for the most part, treat acute attacks of headache as you would for any headache. Judicious use of NSAIDs, fluids, antiemetics, and for secondary prevention, emphasizing good sleep hygiene, avoiding triggers, well-balanced diet, and then some more targeted pharmacologics. Dr. Friedman again.
When I hear about migraine with brainstem aura or hemiplegic migraine, I start to think about calcium channel blockers,
which we've already discussed, have known efficacy in retinal migraine as well, nifedipine, verapamil.
And I also start to think about using lamotrigine, which probably has the best evidence for migraine with brainstem aura. We don't know about the new anti-CGRP monoclonal antibodies. They were never tested in this population.
But maybe they are just as effective. The absence of evidence is not evidence of absence, as they say. It's also worth noting that the severity of these unusual brainstem or other auras do not correlate with the severity of the migraine or necessarily mandate the most aggressive treatments. So just because someone has an intense attack of vertigo with nausea and vomiting, or they become hemiplegic, it doesn't mean that they should be treated immediately with a ditan or repulsive corticosteroids. Experts think NSAIDs and fluids are perfectly reasonable. In patients with aura, the use of triptans remains contraindicated by the FDA, although there is no evidence that triptans cause stroke.
Although I must add, there is no evidence, zero, that triptans cause stroke.
In observational studies of patients with migraine with aura, it appears safe, and some experts believe it's safe and they prescribe it all the time. But some experts also recommend against using triptans for patients who have retinal migraine or hemiplegic migraine, because although, like I said, triptans have not definitively been associated with cardiac ischemia or stroke, as we discussed in more detail back in episode 162 with Dr. Satya Narayan, triptan use has been associated with a transient constriction of the coronary arteries. But if you're going to treat a patient with migraine with aura, since headache does not always follow all auras, as we discussed today, if a triptan is used, then it should be given as early as possible after onset of the pain. That's when it's the most effective. For secondary prevention of migraine with aura, as Dr. Friedman said, lamotrigine has proven efficacy, but so does topiramate, valproic acid, and acetazolamide. And other than calcium channel blockers, there's no other specific treatment that's thought to work better for these atypical migraine conditions. Things not discussed today, but things that are worth looking into for those out there wanting more time to kill during the COVID pandemic: the exploding head syndrome. Not even kidding about this. It's a real condition that was first described by none other than the father of neurology, S. Weir Mitchell. Exploding head syndrome is a very unusual condition of predominantly middle-aged patients in which there's no pain, but patients report their head is literally exploding, sometimes with a loud crash or a flash of light. In spite of its horrifying name, it's actually quite a benign condition. So take a look into this if you got some time.
So I guess my take-home messages are, A, there are a lot of really interesting manifestations of migraine, and they really span the whole brain.
Migraine is more than just a headache.
And many of these symptoms are quite disabling. It's bad enough to not be able to function because your head hurts, but if your head hurts and you're weak and you can't talk and you can't think, that's even worse. So you really have to be on the lookout for these things and eliminate a secondary cause if the patient has red flags for them.
Chemicals like aspartame, as in Dr. Friedman's patient, alcohol, certain food additives.
But I think my major take-home message is that migraine is common and it is very, very rewarding to treat because most people with migraine do beautifully on treatment. And you make such an incredible difference in people's lives. I never thought I would be a headache specialist. My original training is in neuro-ophthalmology, and I love neuro-ophthalmology, don't get me wrong. But my career sort of evolved based on the types of patients I was seeing as a neuro-ophthalmologist. And I started taking care of people with migraine, basically because there was nobody else in town that was doing it, and they were my patients. And they started saying, you gave me my life back. In neurology, especially, a couple of decades ago, we didn't give people their lives back very often. We didn't have that many good treatments. And fortunately, things have changed, but there's still not that many people out there and not that many conditions out there where you really give people their lives back.
Well, thank you so much, Dr. Friedman. This was a true pleasure.
You're very welcome. Pleasure was mine.
And with that, we'll wrap up Brainwaves for this week. Thanks so much for tuning in. And thanks so much for Dr. Deborah Friedman for joining me via Zoom to discuss these unusual headache syndromes. Our episode of Brainwaves today was produced by myself, Jim Siegler, with the help of Dr. Deborah Friedman. Our show is produced out of Studio 3 in Philadelphia, Pennsylvania, with music courtesy of Josh Woodward, Kevin MacLeod, and Lee Rosevear. Our theme song was composed by Timothy Dalton. Sound effects by Mike Koenig and Daniel Simeone. For more information on what was discussed today, as always, you can take a look at our show notes for the references that we used in preparing this topic for today, and follow us on Twitter at Brainwaves Audio. I'm Jim Siegler. Talk to you soon.